Hi, everybody, and welcome to another episode of the ASAP Pathway podcast. I am really excited about our speaker today with us, Dr. David McIntosh. He is an ENT out of Australia. And I must say, if you're on social media and you have any interest in pediatric airway health or airway health in general, you have to know who he is. Extremely progressive, just really trying to educate the community, educate parents on the importance of airway health and the many issues that can occur when you aren't breathing properly. So without further ado, welcome, David, to the podcast. Do you go by David or Dave? What do you prefer?
I've been called many things, and a lot of those things worse than what you've suggested, but David's
Okay.
just fine.
Okay, perfect. Um, what makes you, because listen, when I'm doing this, talking to other dentists all around the country, I give presentations. We try to educate communities all over. And the number one question I get from the dentists in the audience is, where do I find ENTs that understand this? How do I build my team? Because I'm hitting brick walls with the ENTs in town. And what makes you so different, so open, and why aren't all ENTs like you?
Okay, gosh, there's a loaded question. So I guess part of what helps explain the situation is some history about ENT and also just me amongst that progressive things. So where ENTs commonly and typically come into this story is in the context of surgery, in particular surgery of tonsils and adenoids. And if we look at the history of that operation, it started to gain prominence as a procedure really around about the 1920s and the 1930s. And it wasn't so much because we decided to do it, it's because they managed to develop anesthetic agents that facilitated the procedure a lot safer and a lot easier than used to be done. So way back in the dark ages, this procedure was done, but it was literally done, giving someone a huge swig of alcohol, getting them totally drunk, tying them down to a table,
Mm.
and so forth. So very medieval. So I said meant to say medieval, but it is medieval too.
Yes.
So so from that point of view, when the onset of general anesthetic hit the ground running in the time period that it did, that facilitated this operation. And we also need to remember historically at the time that was the era pre-antibiotics, and also the medical knowledge and understanding was not as sophisticated as what we have now. And at the time of things, it was thought that the tonsils were the conduit into the body for all sorts of maladies and illnesses. So, if we look back historically, in the city of New York, there was the Hospital of Tonsillectomy. There was a whole hospital just dedicated to it. And when we look at the historical numbers back then, it suggested that somewhere between 80 to 90% of people were getting their tonsils out, for reasons that were many. And when you pull out old textbooks, which I have done from like the 1910s, 1920s, and it talks about tonsillectomy as an operation and the indications. In the top 10 is snoring. Also in the top 10 was syphilis. So it goes to show that they got some things right and some things wrong.
Right.
But just a sort of a historical context to things. Then antibiotics hit the scene. And around about the time antibiotics hit the scene, World War II also hit the scene, and the world priorities changed a lot. And the use of antibiotics seemed to mitigate against a whole range of infections, not just tonsillitis, but a whole range of infections. And given they thought that the tonsils were the cause or conduit for those infections, they could fix all these other infections with antibiotics. Then it was just like, hey, we don't need to do this operation anymore. So we swung into a period of history where the operation was basically pretty much abandoned. And that was because of the infection story. And then what sort of bounced along as we sort of hit around about the 1970s, And in the 1970s, we started to have a little bit of a sprinkling of a thing called sleep apnea start to trickle into the conversation, but it was in adults, not kids. And then as time progressed, it took about 20 years. When we hit the 1990s, we had a better idea about this thing called sleep apnea in adults. Not a great one. It wasn't really until the early 2000s that we really started to get adult sleep apnea. And then we started to trip out over the kids that were snoring and stopping breathing at night and going, oh, wait, kids are getting sleep apnea too. But hang on a second, these kids aren't overweight or heavy or, the sort of adult sort of thing. But hey, they've got these really big tonsils and adenoids, but they haven't been getting any infections. So let's not get too worried about them. But there was a cohort of ENTs, and this is where I start to break off from the crowd too, who are going, hang on a sec. We've got this group of adults with sleep apnea, and you're telling us about all these deleterious effects with their health and their well-being. And look, we're seeing these kids, and sure, they're not having heart attacks and strokes like you're worried about in the adult population, but these kids are really tired and they're doing really badly during the day because their concentration and their focus and their emotions and their energy levels and their education and their physical activity, it's really lackluster. And yeah, well, look, we'll take it on board that they haven't had infections, and we've tried giving them antibiotics, and that made no difference. So we just bit the bullet and started taking out the tonsils and adenoids, and we just want the rest of you to know that these kids are doing a lot better all of a sudden. So maybe we need to look at the paradigm. And then I was sort of, in this journey of things, I was just in the right place at the right time, because I was in that era where adult sleep apnea was starting to creep into the conversation piece, the early 2000s. This is sort of just the advantage of being, a part of history as it was being made. Mm-hmm. So here in Australia, we had one ENT surgeon that had gone over to Stanford to learn from two guys called Riley and Powell, who were the real pioneers of sleep apnea surgery, at least in the USA. And he brought that adult paradigm back to Australia. And in doing so, I've always sort of had a great interest in pediatrics. My background in terms of how that plays out is way back in the day when I was at university, I was also having to make some money. And the way I did that, I was a swimming instructor. So I was used to working with kids and so forth. So when I came to do my pediatric ENT rotations, I got on with kids just fine. I got the sort of interaction with parents and kids, it wasn't even a thought. It wasn't just a total natural thing to do. And I also at that stage was doing my PhD. So I was sort of buried in the literature looking at the PhD side of things. And in doing so, even though it wasn't related to my PhD, I was jumping the fence and looking at this snoring and sleep apnea and so forth. And realizing that a lot of what I was being told and taught based on the historical context of things was actually quite wrong. So I started to get myself into a little bit of trouble at the stages of my training element, which is not the time you want to sort of start putting your head above the sand. But that's what I was doing and getting it shot off for suggesting that we were not treating these kids properly. And then when I had to finish my training, I went and did a pediatric term, and that was in New Zealand. And as part of that, New Zealand had just literally completed a countrywide review and developed countrywide standards of care and pathway for tonsillectomy surgery. And then about 2 months into me arriving in New Zealand and so forth, there was a paper that came out, or not so much that came out, came to my attention, which was talking about ADHD. And in those kids, they were talking about kids with ADHD rocking up not to pediatric psychology or psychiatry clinics, but to ENT clinics. And they weren't rocking up with ADHD, they were rocking up with sleep apnea and big tonsils and adenoids. But what they did in that clinic is they deferred the surgery so that they could have a psychiatry and psychology assessment. And the guys that were doing that were going, wow, look at all these kids with ADHD you've got in your ENT clinic. And the ENT said, come back in a year. So, okay. So a year down the track from tonsils and adenoids out, they looked at that same group of kids and the ADHD was pretty much gone in most of them, which means it wasn't ADHD.
Right.
So that's kind of, all these little touch points along the way. But a lot of it has come by being in contact with the literature. And I think that's the thing that makes me very different. Even to this day, I've had medical students sort of sit in with me and so forth, like we're in the operating theatre, and just in my in between times, I'm literally sitting in front of PubMed looking at papers, and they're going, "Why are you doing all this?" Because at their stage, they're obviously still learning and trying to apply knowledge, and probably think at my stage I know everything. And I go, because everything changes. There's
Yes.
stuff you're learning now that's going to be wrong. There's stuff that I learned that I know is wrong. The problem is that a lot of our teaching is word of mouth from the person that learned something way back in the day. So part of my challenge to try and achieve getting my knowledge, from where it was sitting to being practically applicable, was that I realized that it's no good me just knowing this. I need to start sharing this, because if I have parents coming in to see me with the mindset, oh, my kid hasn't had tonsillitis, so I don't know why I'm here, I've got an uphill battle. Like I'm
Yes.
starting behind the curve. And the other thing that I realized was there's a huge amount of misinformation out there. And the area that I saw it more placed than any other, interestingly, was in the dental field. And I tripped again into the dental field by virtue of initially one and then two dentists that had approached me as an ENT. And this is way back, let's say 15 years ago. And their comment was, we're finding all these ENT problems. And these two guys were into adult sleep medicine, okay? Adults, pediatric adult sleep medicine. We're finding all these adults and we can't get any ENT to fix them. Now, it just happened to, be fortuitous that I was the ENT that was way buried into airway stuff. And I was starting to trickle my way into the dental stuff, because I was starting to notice these jaw problems. And no one had ever taught me this. This is all self-taught and self-awareness, but it's just like, hang on a sec. These guys are telling me about these adult problems, but these are the things I know happen in kids. Oh, and then you start going too, well, of
Yeah.
course they're seeing them in adults because it did happen to them in a kid. And then you go into these adults' history and they go, oh, yeah, I was always a snorer and stuff, but I never got tonsillitis, so they never worried about it. And you start to go, right, I'm starting to see these adults that these adult dentists are seeing, that are seeing problems that was embedded from childhood mismanagement of ENT problems. But again, the misinformation that was out there was extraordinary. And I don't blame the dentists for that, because again, they had, the same problem. They were learning from people that learned from people that learned from people. And part of that was that at some point they'd probably spoken to an ENT once for 5 minutes and then taken away a life lesson that entrenched them into a mindset. And as a consequence of that being the case, a huge amount of misinformation. And the problem is that when you don't know something, when you come across something new, you automatically put that bit of information in there. And then if somebody comes along with something different, it's actually hard to budget
Yeah.
in terms of move it out of your mindset, because it's something that's an affront to what you believe that you know.
It's so interesting. I mean, there's just so many things that you have said that as you're saying it, I'm just like that and then that. And yes. I mean, what it was interesting, I talked to an adult sleep specialist. She's a sleep physician in New Jersey. And we had a conversation and she goes, what's really interesting to me? It seems like the pediatric sleep is more of this like grassroots movement for some reason. You don't hear a lot about it. And it's like you kind of have to be out there and just dig for it and start collaborating. It's not really open and out there. And like you said, you get things in your mindset, and we get in these paradigms. And just like in the ENT community, we have it in the dental community, and we're not all agreeing in the dental community or in the orthodontic community. And there's a lot of people in our community like yourself that have a lot of arrows in their back because they're saying things that aren't in the paradigm. But it's just interesting, like you said, that there's just a lot of misinformation. But it's like, I think that's what happens when we're not communicating enough with our colleagues, and we're all just in the wild, wild west right now, trying to figure this out and we see patterns, and then it's like, what's causing these patterns? And, a lot of anecdotal things happening in our practices. These are good things. We all communicate with each other. And then those patterns then lead to potential research studies, because if enough of us see these patterns, then we want to study these patterns. But again, the research can be an issue too, because you can get out of the research kind of what you want to get out of the research as well. So you have to be careful with that. What was one of the biggest when you stumbled into the dental community and you got kind of drug into it by these two dentists? What was some misinformation that you were seeing? What was the top thing that you were like, what in the world are they thinking?
Yeah. Well, it wasn't. Yeah. So those two dentists were great. They got it. There was no challenges at all. One of them's now retired. The other one's still working. He still refers to me to this day. And even though that means his patients now need to travel around 600 kilometers, which is around about 400 miles one way to see me. He's just like, you go and see this guy, which is great, because it always sort of makes you feel good that, you're making a difference, that people, cheer you on in that regard. But to answer your question, so the other reason that I got into sort of the education field and actually have a specific course is because here in Australia, there was definitely some things going on that were just totally wrong. And the big one that I saw as an ENT was mouth breathing. That was the number one standout for me. And again, it's something that takes a while to sort of shift the dial on and change perspectives on. But the mindset was that mouth breathing, first of all, was a habit. And we've got to be careful with the English language, because the word habit and the word habitual mean two different things. They're not the same thing.
Explain the difference, please.
Habitual means that you're doing it all the time. Okay? That's all habitual means. That it's something that you're doing pretty regularly. Habit means that you're doing it just because you're in a pattern of doing it. There's no reason that you're doing it. You've just fallen into that groove. Okay?
Makes sense, yes.
All right. The problem is that mouth breathing 80 to 90% of the time is not a habit. It is a response to some form of physical airway obstruction. And of those causes of obstruction, what I saw in the dental community being advocated was it was the narrow maxilla. He said, "Oh, it's the narrow maxilla," and that makes sense, because as a dentist, that's what you're going to know. That's what you're going to see. And the analogy I use is it's raining and there's umbrellas. And you go, well, look, I see all these umbrellas every time it's raining. Therefore, umbrellas cause rain. From a logic point of view, that is a perfectly sound logical conclusion. It just happens to be wrong.
So what do you think about the information with transverse discrepancy of the maxilla? So there was just a paper that was released. Mariana Evans from UPenn, the UPenn sleep team just released it. I don't know if you saw it yet, but just about the deviated septum correlation. So does that relate to an increase of mouth breathing due to the transverse discrepancy, do you feel?
All right.
Potentially?
So I guess what I like to do, when I have these touch points where people are making observations, I like to go, well, let's just rewind for a sec. We got this. What you're seeing is an endpoint. It's not the movie. It's the snapshot. Where are we in that whole movie? Are we at the beginning, middle, or end of that movie? And I would suggest at that point, we're at the end of the movie. All right. There's been a lot that's happened for that person to get to that stage. What was it that sort of, when we look at earlier ages of children, what do they predominantly have as a start point? And they predominantly have problems with enlarged adenoids. That's by far the earliest touch point of an airway problem in the pediatric population in this context. Accepting craniofacial problems, accepting things like choanal atresia, and these rare things. As an aside, around about 3 to 5% of babies are born with a deviated septum. So as a starting point, you can have that there, but most of that, sort of pops back into place. But there's a group where it's residual. But if we sort of just try and look at touch points of timelines in terms of where things can start to diverge, well, adenoid enlargement by far is number one, and the number one cause of that is viral infections by far. And then the other things include things such as reflux, bacterial infections, exposure to cigarette smoke, so secondhand passive smoking. They're really our big four, okay, in terms of adenoid enlargement. But viruses by far, and we worked that out, probably around about 2016. That's when that paper came out that sort of clarified it and gone, hey guys, bacteria, which you've all been chasing literally for the 20 odd years. Yeah,
it's the viruses.
It's kind of there in the picture. It's actually the viruses.
It's the viruses, guys.
Yeah. It's the body's response to ongoing residual viral infection within.
So do you see that? Because again, you do hear this. I think we can get these tonsils and adenoids to shrink if we can stop the mouth breathing. It's like, well, wait a minute. They started mouth breathing because they had the enlarged tonsils or enlarged adenoids to begin with. Correct. And it's like, why don't we get to that first?
Yeah. And it's the same thing. It's just like, hey, I've noticed that when people start putting their umbrellas away, the rain has stopped.
Right. Yes. Yes. Right.
But no. So this is where cause and effect and perspective make a big difference to things. And if this is obviously rain and umbrellas is an easy one because we all know why we use umbrellas and so forth, and we all know why we pull them out and why we put them away. But if someone that was completely foreign to this, looking at us from outer space, was looking at us going, oh, every time they want the water wet, they put these things and point them at the sky. That would be a perfectly reasonable observation if they, didn't understand we're trying to stop ourselves from getting wet. So this is the same problem, is that we have the mouth breathing as a response to some form of physical obstruction. So the touch points again, is mouth breathing normal? No. Is it good for the child? No. Do we want it to stop? Yes. Do we have to teach them that they're doing the wrong thing, or do we need to understand why they're doing the wrong thing? And that latter is the correct thing. There has to be a why. It's not just an is. Mouth breathing is not a diagnosis. It's a clinical sign. Yes. It's an observation. It is a symptom.
Yes.
So you do not treat mouth breathing any more than treating a fever with medication is adequate in terms of then going on and actually having to address the infection that is the cause of the fever. Well, you need to manage the cause of the mouth breathing.
One of the things, sorry, go ahead, David.
You're right. So 80 to 90% of the time, that's going to be adenoids, or then we start to creep into allergies. And allergies is a very interesting dynamic that's changed for me in the past 20 years as well. But by and by, if we look at the big picture, 80 to 90% is either due to adenoid enlargement or nasal allergies. And one of the things about saying, well, all we've got to do is get them to breathe through their nose, well, that might be all well and good in theory, but if their problem is nasal allergies, and nasal allergies are caused by things in the air, and you are then making them breathe more air in through their nose, well, they're breathing in more allergens. So they're never going to get better. You're actually just putting petrol or
it's
gas.
It's a cycle of making it worse. And it's so interesting too, because there are companies out there that have penetrated the dental community, I feel with good intentions, but I mean, it just irks me sometimes to hear what they're saying. And these dentists come away from like a weekend course. They come home with some plastic devices and they're putting them in children's mouths and they're telling them to get them to nose breathe, all these mouth breathing children. And, look, I started doing adult sleep 24 years ago. I can't believe I'm saying that. pediatric probably maybe a decade or more ago. And look, I wanted the answer. Like you said, when you're new to it, you're so desperate for the whys and you want to be part of the solution. And I was so excited about it. I'm like, oh, this is great. And then you realize all the shortcomings. And then I started going, this is just wrong. These kids cannot breathe through their nose. And then they almost feel like, not almost, you're making them feel like a failure because they can't keep their device in because they can't freaking breathe through their nose.
Yeah,
and I'm like, at what point, what are we doing here? Like, we've got to get these kids to an ENT, and totally changed my perspective on a lot of how you approach this. So your beliefs based on literature, experience, your own practice over decades, mostly viral load, increasing the size.
Well, again, that's what the research shows. I mean, the great thing about one thing was doing a PhD is and also having that period of time where I was being taught stuff that I knew was wrong at the time, is also making sure that I don't get embedded in my own belief systems either.
Correct.
So if something new comes along that changes things, and it's just like, well, that's the whole point of doing this. So the way that I approach things, which is a little bit, unusual as a perspective, I'm trying to find out why I'm wrong. I want to know why I'm wrong, because if I'm wrong, I want to know. I don't want validation for being right. I don't want to find things that go, oh, I knew that. Oh, yep, I'm right again. Oh, yeah. I want to find stuff that shows, hey, you're doing the wrong thing. You need to do this. You need to do that. And that's what keeps bouncing through my my system of process, is that I want to find where I'm wrong. And if I'm right, well, look, that's great. That makes me feel good. But if I'm wrong, that actually gives me a chance to be better.
I love that, Dave. I love that, David, because I really feel like the common theme among practitioners that are the pioneers in this right now, that are in the trenches, doing the research, shouting from the mountaintops, hey, we have to help these kids. And, anybody that hasn't read David's books, I'm going to list his books. I'm going to put a link. I love that it's for the practitioner. It's for the parents. But we have to check our egos at the door. And I love that you said, I want to know maybe how I'm wrong. And again, like I said a minute ago, I don't practice the same way I did 5 years ago. I don't even practice the same way I did 2 years ago. And I bet you I won't be practicing the same in 3 or 4 years as I am now. So you have to check the ego at the door and say, what is best for the patient, and be open to the fact that maybe we're not right, or we're right about some things and not others. The thing I hear a lot from parents when I say, look, I pull up the CBCT, I see these raging adenoids. Like, I don't even know how they're breathing. It's blocking the entire posterior nasopharynx. And I say, I need you to see this ENT. We cannot do anything. We are fighting a battle. Your child cannot breathe. And they're so scared of the surgery. And I understand as a parent, you don't want to have surgery if you can do something conservative. Is there a treatment? For a viral load situation where you have such hypertrophic lymphoid tissues, can you shrink if it's a viral load based? Like, what are you going to do maybe non-surgically first as an ENT for something like that?
Yep. And again, I've gone through the whole history loop of this. So the thing that came to our attention, let's just say 8 to 10 years ago, was the suggestion of using nasal steroid sprays could fix a lot of these kids. And as a consequence of that, they didn't need surgery. So I that was, again, it's like, oh, okay, I need to pivot here. So I did. I started doing it. It didn't work. It certainly didn't work anywhere near what they were suggesting in that research paper. They might have got a couple here and there, but in the mainstay, it either didn't work at all, or it worked marginally, or it worked until the kids stopped using the spray, because these kids are not compliant.
Right.
The parents are not going to keep doing this every day either. We know that's a reality. And then 2 years after that paper came out, there was a review of that particular paper. And I suspect it was prompted by people like me going, this isn't working. And when they looked at that paper, it was actually found scientifically to be fundamentally flawed. So their scientific process, their observations, their conclusions, it was all founded on bad premises and bad data, which made then a lot of sense to me. So it's like, right, all right, this isn't working. This paper was wrong. So you go, all right, well, I was wrong to use that paper to change my things, but I was right to know that it wasn't working and give up on it well before this review paper came out. And I think that's the other thing is, if you think you're wrong but then you go and do it and it doesn't work, well, again, not all scientific literature is going to be right either.
Right.
So that's where having, a constructive process of self-assessment helps too.
What do you think
So
is
anyway,
causing the body's reaction to this viral load where it hypertrophies and then just doesn't go back? Like, why can't our bodies just say, okay, I dealt with the viral load, shimmy, shimmy everything out? Why is it stuck there? Why is it not?
Well, I mean, everyone's got this happening in terms of the stuff gets in there and some of it just gets trapped and it takes up residency. It's a bit like when we way worked out that our skin was covered in all this bacteria and so forth. And then there was this initial, we've got to purge the bacteria off of us. It was never causing any problems.
Right.
But because we knew it was there, we had to get rid of it. And then now we've got the same thing. Oh, we've got these viral things in us. We've got to get rid of them. So it's like, well, no, we've all got them.
Yes.
All right. It's just that there is a cohort of people who, through a combination of their, constitutional makeup in terms of their genetics and their environment and everything, just means that there's a cohort where one kid that gets this infection does just fine and the other one doesn't do so well. Why? Because that's what happens across the whole spectrum of infectious diseases in the first place. And, people want to go, well, we've got to get to the root cause. And you go, well, why? We already know what the root cause is. The root cause is kids catching a cold. What are you going to do about that?
Right. Can't do nothing about that.
Nothing. We know that from the sort of history that we've gone through, am I allowed to say COVID without us getting censored? We just got locked down. We saw, oh wow, look, no one's getting these colds anymore. And this is what happens when we open up. Everyone is sicker than they ever used to be.
Yes.
Because those things were just sitting there waiting for us.
Yeah, they're not going anywhere.
Not going anywhere. And then we have daycare, so that's a good breeding ground of an exchange system within kids for things. So we've got to be realistic here. You've got to, it's all well and good to say we've got to address the root cause. Well, look, the root cause is viral infections. You got nothing. We got nothing. We don't have any antiviral treatments or anything that's really going to make a scrap of difference. And we don't know which child amongst the many is going to be the one that's going to clear it versus the one where it's going to be impacting. So what we got to do is just accept that we actually live in a whole spectrum of nature, and this is part of the deal, okay? And everybody wants perfect, but there ain't no perfect.
It is not happening. And so what we have to do as practitioners is remove as many obstacles as we can for these kids and give them the best shot of a better trajectory than we found them on.
Absolutely. Yeah.
That is really what our goal is. We're not going to eradicate all of these different aspects, but when we identify the obstacle, we've got to get them help as soon as possible. And that's the whole thing too, with the watch and wait. Kids will grow out of it. And I mean, they actually grow into it. I mean, they grow into neurocognitive deficits. They grow into craniofacial changes. So it's getting to them as soon as possible. A couple of other things I'm just listening in my head to the moms that are standing in my treatment room when I say get to the ENT. The next thing I'll hear from some of them, well, I think I'm going to start eliminating dairy first before I go to the ENT. What do you feel the role of diet is with inflammation, enlargement of lymphoid tissues?
Yeah. All right. Well, now I've got to be careful. I don't want to be disparaging about your neck of the woods, but I know when I travel to the US, my nose congests up when I have your dairy. I don't get that here in Australia.
That's interesting.
So whatever food processing you've got over there doesn't agree with me, and I dare say it probably doesn't agree with a lot of people. So, but we've got to differentiate things. So the fact that I feel better by avoiding your dairy versus having it doesn't make everything else get better either. It just means I'm not getting worse. It's a bit like, if I have a stick and I'm hitting my arm, and I realize if I stop hitting myself, it doesn't hurt. It's just like, well, that's good, but at the end of the day, with the whole, dietary thing, we've got to look at it at a big picture. It's very easy to cherry pick off a food group
Yeah.
or an item. Let's look at big picture. Let's look across the world and go, well, let's look at dairy. Dairy's easy. There's only 10% of the world population that genetically can, actually cope with dairy quite well. Historically, we were all lactose intolerant.
Yes.
So being lactose tolerant was actually a genetic change that over time, allowed and facilitated us to have dairy in the first place. So there's a whole swathe of the population across the world to this day that don't drink, milk from cows.
Yes.
And they've got airway problems just as much as the rest of us do.
Good point. Good point. I'd like to bring that up to the parents that challenge that to me too. So what would you say to the parents, the practitioner, that it might be hesitant because they're concerned about the potential of bleeding in a surgery?
Yeah. All right. So it's very easy to cherry pick off something that's of concern, and make that the focal point and then forget about the rest of it.
Yes.
So what I try and put people in position and say, look, I totally understand as a parent that you're going to be worried and concerned about things, but I'd like to narrow down your choices of things to worry about to one of two things. You can worry about the problem, or you can worry about the solution.
Agreed. And the statistics for that post-procedural hemorrhage, it happens, but it happens. Okay.
So what we're talking about, just to put it into context for people, is this is in the context specifically of tonsil surgery. The rest of the surgery, any surgery, you can get bleeding. That's just a thing. But tonsil surgery has this little unique element where depends on your practitioner, but for my numbers, it's about 1% of children will have bleeding that is significant enough that it will prompt the need to call an ambulance and to attend the hospital for an assessment. And these days, most of the time, we can manage that conservatively without the need for further surgery. But there's a small number where they do need to return back to the OR to control the bleeding and so forth. So what we're talking about is, let's just use 1 in 100. Okay. So do you accept there's a 1 in 100, that your child could be that child? But then you go, well, that is the risk, but everything we do is a risk versus benefit trade-off.
Right.
And you go, all right. So what are we working, away from as the, the benefits of the intervention? Well, we're working away from the brain damage, and that's what it is. There's no other terminology that's appropriate for it. It is brain damage.
Yes, it is.
As you've seen in one of my books, and I'm pretty black and white. In the Snore to Death book, I talk about the child asleep in their room at night, and someone breaks into the house every night and chokes the child every night. So what do you do as a parent? Do you let that happen, or do you do some form of intervention, knowing that in the process of intervention, look, you don't know if that person's got a knife. That person could hurt you, and cause you all sorts of physical injuries and so forth, or you just go off instinct and so forth, and the fear goes away because at the end of the day, you want that person away from your kid and away from everything. Or maybe you call the police, but what happens if you call the police officer that goes, oh, we know this person, and look, don't worry, yeah, look, they're never going to kill your child, all right? We know this person, they've never killed the child, and so forth. And they get bored of it eventually. And look, it might be by the age your child, after about his age of 6, this person will have just gone away and so forth, and everything's okay, and don't worry about it. In the meantime, your child has had rubbish sleep, has developed some form of anxiety disorder, is having trouble socializing and functioning during the day, but it's okay because it went away by itself.
Gosh, this is such a great analogy.
Yeah, but it's exactly
It is
no
exactly
different.
what's happening. Why are we normalizing a child choking? Anybody choking? And that sound is not, I tell patients too, because they give me the eye roll, oh, my dad snored, or, oh, and there's just too many silly memes out there normalizing and making fun of snoring. So society sees it as a very benign issue. And we know that even snoring without a diagnosis of OSA has comorbidities and needs to be addressed. Children have heart problems from snoring. They have heart problems.
Even just from mouth breathing. So if we rewind back to the mouth breathing for a moment, because I like to sort of highlight, because one of the things that's out there, which you alluded to, is all we've got to do is get them breathing through their nose scenario. So let me just explain in very simple terms some very complex physiology and then pathology. So when the adenoids are big, like you see on your CBCT, they're enormous, and this child is mouth breathing. When you mouth breathe, you're breathing air into the top part of your lung versus the bottom part. When you nose breathing, you're breathing into the bottom part of the lung more than the top part. The reason that slight difference is important is because the blood flow preferentially goes through the bottom part of your lungs. So when you're mouth breathing, you're diverting air away from the blood. So that drops your oxygen level down a little bit. So that's why nose breathing is more important, because it gets the air going into the parts of the lung where the blood is, so that things are matched up appropriately. But here we have this mouth breathing child. Now, what we're going to do is we're going to take their mouth shut and we're going to force them to breathe through their nose. Now, if there's some sense of just a little bit of an airway, you can overcome airway obstruction with increased respiratory effort. So they work harder. It's like, and practitioners that are familiar with this will understand this. I don't know how to convey this to the general public, but basically, if you were to have actually, I do know how to tell it to the public, but just bear with me. If you were to be drawing up a medication for an injection of some sort, you and I both know that if we use a wide bore needle versus a small one, it's much easier to draw it up through a bigger needle than it is through a small needle. Same fluid, same syringe, but if we pull really hard on that syringe plunger, we can eventually draw it up. Well, that's the same thing as these kids. If they've got a little bit of an airway, if they draw their plunger being their diaphragm and their chest wall and so forth, they work that harder, they will be able to drag the air through into their lungs with force and effort. The way that we breathe is that we generate a negative pressure level in our chest, and that's what drags the air in. What people miss in this conversation is it also drags in blood into the chest. It's one of the ways that we facilitate blood returning to the heart. Every time we breathe in, when the chest wall base pressure drops, that draws blood into the lungs, which is then transferred into the heart. Now, in mouth breathing kids, they have a dysregulation of their heart function, because one of the compensatory mechanisms for blood flow through the lungs to try and force it to where the air is that the blood vessels in the lower part of the lungs will go smaller. They'll shrivel down to try and force less flow of blood through the lower part to force it up to the upper part. When they have this large volume of blood that comes into their lungs and their blood vessels are already constricted, the heart then has to pump out a large volume of blood against a vascular resistance, and so forth. So now we're trying to push things through that small needle, not pull it up through the small needle. And we're trying to push a lot of it, and the heart has to do it in the same rate of speed as it would normally. And it starts to fail. So these children, you're actually causing heart damage by forcing them to mouth breathe when they have nasal obstruction. So it really just goes to the whole issue of of well intentions, but not understanding consequences as to how this can play out. So sorry to sort of take you on that little tangent there, but I think
No,
it's
that's
just so
so
important.
important. It's so important is having these conversations, not just don't do it, but here's why you shouldn't do it. I mean,
Yeah.
what are your thoughts on? There was a paper, and this is being circulated too. There was a paper out of Stanford with expansion of the maxilla on, they had enlarged tonsils and enlarged adenoids, and the
Yep.
tonsils and adenoids shrunk post expansion, 40%, I guess, in decrease in volume of the adenoids in that paper. What do you think is the resulting decrease in size from? What do you think that is?
Well, you see, this is where you need to have a control group.
And this is
Okay.
where it's tough. Yeah.
Yeah, you need to have a control group where you do nothing to see what happens. And we've got something pretty close to that in the what's called the CHAT, Childhood Adenotonsillectomy Study Cohort, which is about 10,000 kids. It was done in the US. And they basically watched through these kids with doing nothing, using sleep studies as their parameter. And again, it opens a whole Pandora's box. But they used sleep studies, and they said, look, if we could take a sleep study at time 0 and a sleep study at 6 months, what they found is around about half of the kids with diagnosed sleep apnea did not have sleep apnea 6 months down the track by doing nothing.
Right.
So
I recall
when you
the
look at
CHAT
that
study. Yes.
Yeah, so when you look at that Stanford paper that you're referring to, it's just like, well, how much of this is these kids just getting better because they were getting better in the first place? The
Well, I
second
think
thing,
in that study, didn't they have a control group that it was during COVID? So they
yeah,
had a group of parents
yep,
that
they did.
didn't do anything, because you can't
Yep, and
really not do anything
yep,
ethically,
yep.
but they didn't do
Parents leave.
anything because the COVID shutdown, they weren't going to have the surgery. So they're like,
Right.
let's
Yeah.
just go ahead and
Yep.
do the expansion anyway and
Yep.
see what
Correct.
happens. And then another group just waited and did nothing.
Yep. Correct. No, you're absolutely right. That's where Stanford was a little bit different. Is they had that sort of comparison to sort of look at, well, these ones got better more so than the others. So I think it's very encouraging to show what benefits can come from that treatment. The downside to that paper is, first of all, is they used a sleep questionnaire. Sleep questionnaire is not a measurement of severity. It's a basically an indicator of which of these kids from a general population, if we were screening, warrant further assessment and treatment. And all of the kids pre and post treatment fulfilled that criteria. There's just that they had less of the criteria after the treatment than before, but they still had the criteria adequate to need. The other thing is that those questionnaires, not every question has an equal weighting if you were to weight it clinically. So, if the number one question was, does your child have sleep apnea? Well, it doesn't matter what the answer to the other 10 questions are.
Yeah.
That one single question is a concern. So let's say what that one question, say spin it around, then child number 2, no, they don't have sleep apnea, but they answered yes to every other 10 questions. Which child's worse? The child that's got sleep apnea, or the child that answered yes to the other 10 but not sleep apnea? It's not a rating scale of severity. It's just an indicative
It's a
scale.
presence of, yes.
It's an indicative measurement of how many of these kids, because we've got limited resources and limited time. Here's a quick thing. Tell us what's going on. All right, your kid. All right, we don't have the pertinent question. So it's like, if you answer yes to this question, ignore the rest of the survey because the rest of it doesn't matter. So that's the other thing about that paper that came out. The other thing that was somewhat novel about that paper is they were using tissue volume.
Yes, because they're showing CBCT before
Yep.
and afters. And some people were saying, well, is it that you created more space, so it's smaller within a relative space? because you made a bigger space, but their pushback was no, we actually measured the actual tissue itself. So relative, it was separate from relative to its orientation in a smaller versus a larger space, the actual volume decreased. So back on what you were going to say about that.
Well, that's exactly right. It's actually not the right measurement. The right measurement is the airway, because it's we don't really care if they've got big tonsils in a big space. That's fine.
Right. It's all relative to the area in which they live.
It's a very simple mathematical equation. Airway space equals potential space minus that which is occupied. So what we need to be measuring is the airway space, and then we need to be measuring it from a functional point of view. And that's where, sleep studies, is one parameter. Not that they necessarily measure everything that's right based on the science. But anyway, that's a rabbit hole that we won't go too far into at the moment. But, so that paper that came out showing expansion, my take home from that is, if the parent is going to do nothing, well, something is better than nothing.
Agreed. I mean, and they need the malocclusion addressed anyway, which is what the point of the, dental orthodontic healthcare practitioner is. Look, I see a malocclusion probably from an airway problem. They're still not moving forward. I've got to create more space for the tongue. I've got to create a better arch and do my arch development. So, but I will say, I mean, you do hear anecdotally that some orthodontists are like, I don't know what happened. I'm expanding and I see not full resolution, but some improvement. And this is where Guilleminot's paper of, it's a combination of working with the ENT, working with an orthodontist for the craniofacial, or dentist comfortable with working with the craniofacial changes. And then the third piece was myofunctional therapy, because this child has basically atrophy of muscles they've never even used before, or hypertrophy of using muscles they shouldn't have to compensate. And putting those three together just tended to have the best long-term prognosis. But
exactly.
There's just too many dentists and orthodontists just not even screening and referring to these ENTs. I mean, what would you say? And here's another part before I get into what do you want dentists to understand and know, an orthodontist. Acid reflux. Let's talk about acid reflux a bit. I feel like I just was checking in on a friend of mine who had preterm twins. And I'm like, how you doing? She's like, I'm great. I'm exhausted because my babies aren't sleeping. And so I wrote back, especially with preterm babies, acid reflux tends to be because they don't fully develop. The sphincter muscle isn't as controlled as it should be. But I've also heard things like low vitamin D, different nutritional issues. Like, we're seeing such an increase in this acid reflux in children, which can then, it's like the chicken or the egg. Acid reflux can make sleep disordered breathing worse. Sleep disordered breathing can make acid reflux worse. As an ENT, where do you even start in that whole chicken or the egg? And why do you think we're seeing so much acid reflux? Or are we seeing it more? Or has it always just been around and we're just identifying it?
Well, we've got to be careful about who's diagnosing it, is the first thing, to be honest. Because as ENTs, we've known about this acid reflux in the context of a condition, particularly in the neonatal infant period, of two main conditions. One is called laryngomalacia, and the other one is called subglottic stenosis. And in both of those scenarios, reflux is a cofactor, driving factor. So, it's all part of the story. But we are diagnosing that by clinical assessment of physically looking inside and seeing the characteristic changes of reflux. Most reflux diagnoses are made on clinical grounds rather than actual physical assessment or testing. It's basically educated guess. What that means is you don't actually really know. And you've got to be careful about who's making the call as to who's got real, experience versus doesn't. And it's a very easy diagnosis to label a child with, and then sort of go down the medication pathway, where in actual fact, that's not necessarily the right thing. Some kids are spewy, chucky babies, and that's not reflux. Some babies get abdominal distension and burp and fart a lot. That's not reflux. Certainly not in the pathological sense of things. So, so that's part of the challenge, is that it is ultimately in the majority a clinical diagnosis. When it's significant and worrying, that's when you'll start to land on the professional's doorstep, whether it's a pediatric ENT or it's a pediatric gastroenterologist. They are probably the only two people, in terms of specialist level, that can physically look to see if there's changes of reflux, albeit in different parts, whether it's within the upper airway or whether it's in the esophagus.
Would you say that they should just go straight to the ENT if they're suspecting that? Or do you, I don't want to step on the toes of the pediatrician, but it sounds like, what do you think about a pediatrician diagnosing it and trying meds versus maybe you should go to the ENT first?
I think ultimately that, given that there's so much potential of this around, and we've got to look at how we use our resources, I actually think the trial of medication, if it's deemed significant enough, the trial of medication and so forth is what most of us would do anyway. We would say, look, it's probably reflux, try this. If it settles it down, all well and good. But here's the other things you need to do as well. You need to position things up. You need to sit them upright for half an hour. Elevate the cot so that they've got a little bit of gravity working in their favor. If you're using bottle feeds, here's some thickener to try and change the consistency so it's not so watery. It's a little bit more on the solid side of things. They're less likely to bring that up. And then, look, here's this medication which is only a short-term band-aid to things in the mainstay, just to, settle down the irritation from their reflux, which should be short-lived and should be, self-limiting. So that's that context. The ones that then go beyond that, where, they've got those other things going on that I mentioned, or, it's just way out of control, and they need to see that next level. That's when you pull the trigger there. So I think it's perfectly reasonable to have your baseline, just knowing that there's levels to everything.
What age, what is the youngest that you have completed tonsil and adenoid removal in a child that you were comfortable?
Youngest tonsils I've done was 11 months old. Youngest adenoids I've done was 5 months old. The youngest kid I have heard of having their tonsils and adenoids out was 6 weeks old.
Oh my goodness, 6 weeks old. And so obviously the parents, somebody saw this child is not breathing well.
Is an extremist, yeah. Obviously, it's a pretty big deal to do a 6-week-old, but there's this whole thing, they're too young to have surgery. It's like, no. They're too young to have this problem.
Thank you. Yes.
The younger it starts, the worse the long-term damage.
Yes.
Because they are on a trajectory of brain development that has been compromised. When you look at what the brain needs to develop, it needs nutrition, energy. And most of that comes from sugar. That's what the brain predominantly survives off of, is sugar. So it needs an energy source. It needs oxygen, and it needs sleep.
Mm-hmm.
Okay? If you have a child that is not breathing properly and not sleeping properly, well, you're 2 out of 3 gone. And we know that these breathing problems affect gut function, which then affects their metabolism. So now your whole metabolic background is changing for the worse as well. So, there's just layers of badness to this. So again, if you go back and say, look, you can worry about the problem or you worry about the solution. You've got to worry about the problem. You should be glad that there is a solution. It may not be the solution that you're comfortable with, but you should be glad that there's a solution.
And so what would you say on that? All the research is pointing to this, the neurocognitive deficits. You've got to fix this, and you got to fix this by 4 or 5. After 6, some of this is permanent. It's locked in. You can't fix it after 6.
Yeah, well, there's two things. It's actually worse than what you've just said. Um, the brain has this element of neuroplasticity, sort of adapting and changing all the time. It's just that it doesn't do it as well as we get older. So the worst outcomes are if it's after the age of 6. The better outcomes if it's before the age of 6, in terms of what you just referenced. But there's another one there too, and it's the duration of exposure. And it doesn't matter what age you're looking at. Anything that's beyond 6 months of duration of exposure is when the permanent changes start to be evident. So it started when they were 12 months old, and you do nothing until they're 24 months old. Well, that's 12 months of exposure. And yes, you're going to see improvements and you're going to see benefits by then getting it fixed at 24 months. But there's bits that are basically entrenched that are not going to work properly because they weren't built properly to start with. It's this, these little, it's like people doing computer code, and, they make these tiny, tiny little errors that may not show up until iteration 5 million. And then when you get to 5 million, then you start to see the problem. Well, it's the same as your child. You're not going to notice these little things at 2. You're not. But you might start to be the parent of the child who is disruptive in class, who's having trouble with their reading skills, is having trouble with their math skills, is having trouble with their sporting, coordination and fine motor control with handwriting and so forth. And you're not going to make the link. You're not going to make the association, because it was that you just have the child that you've always had, and everything that grows and develops with what you see as being normal. The way I look at it is that we just want to be in a situation where every child has the potential to reach their full potential. And to do that, amongst the many, many things they need good breathing and they need good sleep. And the science shows when we send these kids through the scanners, historically what we've been doing is measuring brain volume functions. So looking at different parts of the brain that we know different things, and looking at how big or small these parts of the brain are. The thing that's come out, and it's taken a long time because the technology's been around for over 10 years, and it's been done in brain mapping in the autistic brains in particular. But this paper's only literally just come out. And again, it'll be shared on the Facebook page, I think, in the next few weeks, just logged with other things. But this paper is looking at what's called brain mapping, okay? And what it is basically looking at, look, these are all the parts of the brain, but if we start with point 1, where are all the points that it connects to? And look at point 2, where are all the parts it connects to? So basically, it's like getting the map. So if you look at, like something like Google Maps from above, really, really high up, you'll just see the main roads. And as you zoom in, you start to see the secondary roads and the tertiary roads, and then the back alleys and the laneways and so forth. Well, that's what they're doing in the brain, and they're then going, here's the whole connecting, and look at how the spread of these connections in these kids that are not breathing and sleeping properly differs to otherwise well children, and it's markedly different. These children have what's called nodes. They have less nodes, so less connecting points, and then as a consequence of that, they have less distribution points. And they also have shorter pathways. So if one part of the brain is trying to reach the other part of the brain, it's not necessarily happening. So from that point of view, it's not just that these brains are developing abnormally in terms of volumetric, but they're also developing poorly in terms of connections. And it's those lack of connections that are then going to flow on to functional problems, but not at the time that you're going to necessarily notice, because it may not be the sort of functions that child is up to at the moment. At the age of 2, I mean, they're not doing
math and trying to do cognitive, which is, it goes back to Ghazal's paper. This mapping is going to be really interesting to look at, because it's going to support, I'm sure, that Ghazal's paper.
I've been waiting a long time for this this research to come out, because it's been done, in the autistic brain, research showing how the whole connection mapping thing is different, and then understanding why manifestations of things are such as they are, just trying to get a handle on things.
Well, they know the autistic child tends to struggle with sleep more so than the non-autistic child.
Well, yeah, and that's again another rabbit hole that
Yes,
just
that's
shows
another rabbit hole. We'll have you back for that.
Yeah. So,
but like Gazal's paper was talking about the 13-year-olds that they studied who do not
correct.
snore, but they
Correct.
did between the
Correct.
ages of 4 and 6. So they
Correct.
don't snore any longer. So they
Correct.
grew out of the snoring. However,
Yep.
they were all in
Yep.
the bottom third of their class. So the delays, the cognitive deficits don't always become evident. You look at
Yep.
little Johnny and little Emma at 2, and you're like, they're fine. They're hitting milestones at 2 and 3. You're being dramatic, Dr. Ochoa. I don't think I need to see an ENT. Well,
Yep.
History is showing us they're not going to fare well. They're just not.
No. And the pivot paper there is the one that came out with Karen Bonnock from University. So,
big study. That was a great study.
Yeah, there was 12,000 kids where they basically did nothing, and watched these kids, and the kids that developed this is where the 6 months comes from. Developed 6 months of consistent time frame sleep disordered breathing, and then looked at their outcomes at the ages of 4 and then the ages of 7. The outcomes were poor in those children, even those where they said, look, the child outgrew the problem. If we considered the problem to be airway, if our narrow focus was the airway is the problem and it went away, the problem went away. But then the reset is well, did it actually leave anything, unscarred? The answer is no.
No.
These kids are damaged. They are damaged. So from an ethical point of view, it's even amazing, and I think it was only by COVID, fortuitously, and the fact that parents were refusing surgery, like they advocated surgery and they refused it, that they could run that Stanford thing with the expansion.
Yes, yeah.
But again, their outcome measure that they used of improvement, in terms of function, was a sleep questionnaire that is not a diagnostic questionnaire of severity. So from that point of view, there's a falling down there. The other thing is, when we look at expansion, as you know, the bugword of expansion is that word called retention.
Yes.
So how many kids do you expand against some form of airway resistance that then relapse?
100%. You're fighting a battle with that. Yeah.
Exactly. So what's interesting for me, and again, I don't have any special superpowers. I just make observations. I have a fantastic working relationship with a multitude of dentists that have been doing airway stuff longer than I've been doing ENT stuff. And one thing I've noticed, from their approach to things, now that they've got me as sort of part of their treatment protocol and pathway, is they will absolutely refuse to do any form of orthodontic expansion or braces or the like until the ENT stuff is sorted. And the reason they say that is they say to me, well, there's 2 reasons, David. The first reason is that we're just finding it's easier to do it when these kids can breathe better. And the second reason is it's sticking more so than it ever used to, and so forth. So we're in a situation where not only can we fix these kids better than we used to, but we can keep these kids better than we used to. So from a moral and ethical point of view, I just can't take parents' money knowing that their long-term outcomes are not going to be ideal.
100%. And I even have that in my consent form. Like, I am not, if you do not follow my, instructions on collaboration with the ENT, we're not doing this, because it's going to fail. It's going to fail. And your tongue is not only nature's expander, it's nature's retainer. And if your mouth breathing still, your tongue's still in the wrong place that got you in the problem in the first place. What would you say? Sorry, you were cutting out. Well, go ahead.
I was going to say, my functionally everything's wrong. I mean, you're setting yourself up for failure.
Yeah.
You're literally stretching a rubber band, expecting that it's not going to recoil on itself again.
Yes. And that's a whole other rabbit hole too, is just what type of expansion tends to be the best too. And that's a whole rabbit hole that dentists are in right now. But if you could, so I wanted to talk a little bit about what you want dentists to know and the best way to refer. I tell you what, I get a Facebook message from a mom dentist probably 2-3 times a week. This is my kid's symptoms. Here's what's happening. I don't know if it's allergies. I don't know if it's an obstruction. I don't know what to do. Do I do a sleep study first? Do I go to the ENT first? And if you would have asked me that question a decade ago, I was sending everyone for sleep studies. I do not do that anymore. And here's why. The majority of sleep studies come back normal, meaning the child does not have obstructive sleep apnea. We know that anywhere from 3 to 5% of the pediatric population might have. It's not a lot that have obstructive sleep apnea, which is really end stage disease. I mean, they're sick if they have OSA.
Yep.
The issue is when the study comes back normal, it gives the sense to the parent that the child, their sleep and their breathing is normal when it is not. And all these sleep physicians are like, look, Stace, you've done the right thing. You've sent him to me. This child is sick. They just don't have apnea. I don't know what to tell you. So I started switching it up. I go, the bottom line is they're not breathing well. So that's why they're not sleeping well. The sleep is fragmented. We're going to go straight to the ENT now. And then I let the ENT decide if they want to do a PSG on the child pre-surgery. The other thing I tell parents is I want you to go straight to the ENT, but please go record their sleep if possible, because that gives that ENT some good information to see, are they tossing, turning? Are they mouth breathing? What is happening in the sleep? What would you say differently? What else could we do to equip that parent to come to that visit to you best?
Yeah. So what we need to do is get the terminology right. So, and again, this is sort of steeped in history, like as I said at the opening, in terms of how we sort of started finding these kids with sleep apnea because we were dealing with these adults with sleep apnea. So we started treating kids as little adults, but they're not. So the first touch point is that sleep apnea is not the defining line in the sand of a problem. The proper terminology is sleep disordered breathing.
Yes.
And that is mouth breathing, that is snoring. It's what we call upper airways resistance syndrome and sleep apnea. And a sleep study will be able to see the sleep apnea bit, but it misses everything else.
Yes, it does.
All right. And there's a whole range of analogies that you can think about here. So, for example, if we were to look at lung cancer, one of the ways we can look at, if you've been a heavy smoker and you might have lung cancer, is we can do a CT scan and we can look through your chest and so forth, and we can find the lung cancer. All right. But you could have a skin cancer at the same time. We won't see that on the scan. Okay. They're both cancers. It's the same with airway. Mouth breathing is an airway problem. Sleep apnea is an airway problem, but the study is only looking at one thing. You can have mouth breathing and have a normal sleep study because you're breathing around the obstruction.
Right.
If the obstruction nose and you're breathing around the obstruction, well, you're not going to measure any obstructions because there is no obstruction anymore in terms of how you're measuring it. So a normal sleep study does not mean normal breathing.
100%. And boy, did that years and years of what I thought was the right way.
Yep.
Which healthcare provider I punt to first. I do not do it that way because I got too many false, everything's fine. Well, yeah, they don't have OSA. I'm glad. But they still have sleep related breathing issues.
So that's the first thing. The thing, just to sort of keep moving through on that one, is that sleep studies, if they're going to be done properly, need to be done 4 nights in a row to get an average of things rather than a snapshot. The other thing is that the sleep study, even when they've got sleep apnea, and we sort of have this arbitrary mild, moderate, and severe, it actually doesn't categorize which child will have the greatest benefit from surgery. So it doesn't tell you which child has a problem. It doesn't tell you which child needs to be fixed.
True. This is where the whole algorithm of even AHI has its own problems.
And it doesn't tell you why they have a problem.
Right.
So from an investigative tool, it's really not that great.
Yeah.
In terms of what we're trying to, for the intended purpose. The intended purpose is to find kids that can't breathe and sleep properly. that still to this day comes from history examination, and you're absolutely right. The use of the phone these days makes it so much easier.
Well,
It
that's
really
good.
does.
Okay, good. I'm glad you find that useful. I'm telling parents to record the sleep because I think you're getting a lot more information than probably because you're missing a lot with the PSGs. And even, you know, the AASM, which is the American Academy of Sleep Medicine. I mean, they understand that there are things being missed in certain populations with PSG and in the adult population, HST. I mean, if you have darker skin, you're missing things. If you're a skinny female, we're missing things. If you're a child, we're missing things.
It even depends on which criteria you're using for your hypopneas, whether you're using
Yes,
a 3
3
or 4%.
or 4%, and that
Yeah,
100%. And I think that's
yeah.
changing too. I think in 2024, I think the AASM is including, I believe they're including the 3%, because I think it's Medicare that's the 4%. I can't remember, but
And again, this is part of why I think you run into problems in the USA. Is that a lot of your healthcare decisions are driven by insurance products and policies.
Yes,
So
it's amen to that. That's a big problem right there. It's driven by reimbursements from insurance.
Yep. So one of the problems that I may be inaccurate in stating, but this is only my understanding, is that for some of the policies that they'll only pay for tonsil and adenoid surgery if they've got tonsillitis or if they've got sleep apnea, and they have to have had a sleep study to prove it. So if that's correct, you know, that is also then, you know, obviously saving the insurance company a hell of a lot of money.
Oh,
But at
100%.
the time,
Yes.
as another aside, and just, you know, if everyone wants to sort of take us up on the offer, when you do the math, when you look at your co-pays, even you do have an insurance product, it's actually cheaper to jump on a plane and fly to Australia and have your surgery here at times than it is even just with your co-pay and so forth. And if you don't have insurance, it's definitely cheaper to come to Australia and get
Yeah,
it done.
there's definitely some very broken aspects to American healthcare. There's no arguing that at all.
Yeah.
And even just having, like, I have parents that say the sleep studies alone, you know, the copay for that was like $800 to $1,000 for the sleep study. And man, you want to have an aggravated parent when their dentist convinced them to go have the sleep study, right? They paid $900 for it and it came back normal. And I'm like,
Yep.
how your child's still sick. Please go to the ENT. Now I lost them. They don't even want to go at that point. That's why I changed my whole paradigm of who I'm referring to first. I love my sleep physicians. I have so much respect for them. There are over 80 different sleep disorders, only 2 of which have to do with really the airway. So they have a lot that they're dealing with. But just there's just things being missed. And David Gazal is really pushing for changing how we're diagnosing these sleep related breathing disorders through maybe biomarker testing, through blood tests.
Great.
Who knows how long that's going to take to come out, but it's very promising to look at the actual biomarkers on these kids and say, they're sick. It has nothing to do with an AHI. Let's look at their biomarkers. They're sick. Which on that topic, you are co-authoring a book, a textbook that's hopefully going to be used in the medical and dental community, calling Growing into Breathing Problems. And you have an orthodontist, yourself, and a world-renowned pediatric sleep physician together. And it's called The Quest for Collaborative Lifetime Solutions. I love that. The other book you have is Sleep Disordered Breathing, A Parent's Guide. I think everyone should get that. Don't ignore the snore and then snored to death. And I love your analogy of, would you be okay with someone slipping into your house every night and choking your loved one? Because that's exactly what's happening. And that's a really good analogy that I'm now going to steal. And I'm going to use that with my patients that don't want to go. I appreciate you being here. I feel like I got to have you back because there's just so much more to say. And I had 3 questions for you, and it'll be interesting because you're from Australia, so the culture's different. But I like to take people down, you know, memory lane a little bit to their childhood because I think it's so important. We're all just pretty much, you know, grown-ups, but kids inside. So I had 3 questions for you.
Sure.
One was, what was your favorite cereal when you were a kid?
All right. You'll never have heard of this, but this is a very Australian thing. So it's called Wheat Bix. It's spelled Weetbix.
Wheat
All right.
Bix.
Wheat Bix. So you have to go and do a little dive on that one. All right. So I'll
So
leave that one with
it sounds like little wheat biscuits, if I had to
correct.
guess. Okay.
Yeah.
Did you eat them plain or did you pour sugar all over them? Like, how did you get that down?
So pour sugar on them. So we would have them
Yeah.
with milk. Sometimes put banana on them, and then
Mm,
go totally Australian on you. If we were to eat them plain and dry, we would put Vegemite on them as well.
Vegemite. Okay, that's very Australian.
Very much so.
What was your favorite movie when you were a kid?
Oh, when I was a kid, that's a
Yeah.
good. I got to think back to my childhood. Oh no, I got it. Batman, the original Batman movie.
The original Batman.
Yeah, the one
Well,
with the shark spray.
oh my gosh. See, that's mutual. I know that movie.
Yep.
That's a mutual
I'm,
one, no matter what
I'm
country you're in. What was your favorite after school special or after school show when you were a kid? You come home from
after
school
school.
and you'd watch what?
I don't think you probably got this in the US, but it was a show called The Goodies, which was an English comedy show. Three guys. You'd have to look it up. When you go and watch it these days, it's totally politically incorrect, and
As
there's so many
most
things.
things were when we were kids.
There, there's so many things there. It would never get an airing in the US. One episode I can think of in particular would never get an airing in the US.
Well, now I'm gonna go watch the goodies
Yeah,
after that.
yeah. So it's called The Goodies. Goodies.
Okay,
English,
I'm looking it up.
different comedy to what most Americans are used to, but Australians sort of gel more towards the English than the
Yeah,
American side of things. So yeah, The Goodies.
the goodies. Well, I appreciate you being with us today and taking us on this journey because it's important and these kids really can't wait. And I'm going to put a link for all your books and just how people can find you in general if they're looking for a consultation or even flying to visit you because they're not getting resolution with their local ENT. So I'll get with you after and make sure I put all those links so people can find you, David. I appreciate you very much.
Stacey, what you're doing is excellent. So anything I can do to sort of just cheer you on, I'm totally on board with that.
Well, I appreciate you. And thanks for taking the time today. We'll see you all later.
It's been a pleasure. Cheers.
Bye.